Right, let's talk social prescribing. As you say, it is a very hot topic, isn't it? So conflicts of interest. I am clinical director for Social P, the group themselves. I'm not paid for that, and I have no other conflicts of interest. So if anyone wants to pay me, no. So what we're talking about here is a bit about social prescribing and the background, but really wanting to talk about the outcome measures and the evidence itself. A little bit about looking forward, but we've only got 20 minutes, so I want to be a little bit concise. There is a lot to get through. So yeah, GP, very proud to be a part of the BSLM, one of the London directors and the social prescribing director, and I'm also, yeah, clinical director for Croydon Social P. So I think everyone knows what social prescribing is, but just to say it, it's connecting people to wherever they need in the community, the non-clinical resources. It's but I think it's more than that. It's also identifying and supporting the community. It's also making sure those resources are as good as possible, as effective as possible. And I like to say it's by the community for the community. Another way of putting it is that it's recreating that community. I think a lot of us might have heard of a few different parts of this, but the history is very interesting. If you haven't heard about the Peckham Project, Google it. It's amazing. So in 1926, it was set up as a community health and wellbeing centre, with the health of people being measured and linked with their social connection, something that we can all really empathise with now. I think most of us have heard of Bromley by Bow. So I won't go on about it for too long, but again, a wonderful and innovative community resource that everyone benefits from. I think it's worth mentioning that most people know the skills inherent within their community, whether that's friends, families, etc. We're very social beings. We understand the skills that are around us as well as our environment. And unfortunately, our communities have become extremely small. We've become isolated from those around us geographically. I don't think technology has helped that, but Aviva did a very interesting survey that found that 1 in 8 people surveyed didn't know any of their neighbours. So that's about 8.5 million people in the UK. The average UK adult knows just 4 of their neighbours. I think you and I both know that the people that are in those statistics and suffering from those statistics are the most vulnerable. And we know that social isolation is an independent risk factor for disease. COVID-19 has definitely not improved this. And it's definitely critical that we do improve people's social connection, and social prescribing is a fantastic way of doing that. Here's a little interest over time. So it's a relative thing, 100 being the top and percentiles of that rather than any direct metric. But it's interesting to see, isn't it, how interest is going up over time. And you'll see that that correlates nicely with the amount of literature coming out as well. But what about social prescribing now? Talked about the history. I think most of us will recognize that, that classic model. We know that, that classic medical model of probably very, very didactic that we all learn in medical school. Most people require an additional social support to that. In fact, 20%, it was estimated, are just primarily social and not really medical at all. So they'll come in, they'll see their healthcare professional. I would like it. And in some areas, it isn't just a healthcare professional. You can access it wherever. They are then referred to a link worker of sorts, who then supports them, coaches them, and signposts them, directs them, and puts them in with good quality local resources. They can then come back through that cycle, and they should never be blocked from seeing their GP or their healthcare professional just because they're part of their social prescribing. It's an adjuvant thing, and it may well take away from appointments, but that's something we'll discuss in a bit. A very interesting part of all of this is everyone's coming up with their key elements or their essentials for social prescribing. I like NHS England's one. It has the link worker at the centre of it, talking about easy referrals, collaborative working, development of that workforce and training, personalised care, support for community groups, and common outcomes framework. That last one is very, very important. We'll discuss that in a bit. The Richmond group actually came out with something very similar. which I also think is great. I probably prefer it. I think we do need good quality buy-in. It must be person-centered, very similar. Connections, again, that's the same as the previous. Transfer of resources. Often what's happening is our funding is following general practice, but it is not funding the community very well. And that's really important to remember. We're not offloading general practice. We must be effectively funding the community as well. And then community building. So how does it work? Well, it's so incredibly complicated, but these are some of them. We know that we can improve people's skills and knowledge. We can create leaders within the community. We can highlight and make more effective areas of support. We can reduce reliance directly on healthcare. Indeed, we can improve people's faith in health and social care, reducing isolation as well. There's so many. But let's really talk about the evidence. Let's get in there a bit. And again, this is such a complicated topic. I have distilled it a little bit. Now we have, obviously everyone knows about qualitative and quantitative. We have so much qualitative data. Changed my life. I paid double if I needed to. Friends for life. I feel confident to leave the house. I love the session. My particular favorite, the trainer was dishy. So, you know, people out there enjoying their sessions. They are changing their lives. But you can't sell a service to the commissioners just on qualitative data. We need quantitative, but is that really the answer? Everyone recognizes this pyramid. I won't go over it, but we must remember, and just to make the point, individual studies, even if they're excellent quality, only say one thing or add a very small amount to the entire data field. A bit like the Daily Mail and their headlines, we have to be very careful taking an individual study on its own. Most of us as well don't have time to critically appraise what we're reading. So we must be very careful. And also randomized controlled trials really aren't designed for something as complex and social and intricate as social prescribing. They're really designed for drugs and something with relatively simple outcomes. We also know that evidence lags behind. It takes a long time. It's expensive. You can't always measure everything, right? You can't measure the look that a patient gives you when they get it. You can't measure the conversation that they then had with their husband, their partner. Another thing is you don't always have to and can't prove that some things are good or bad, whether that's for ethical reasons or just because it's so obvious. You know, parachute, we don't need to check that parachutes are good for skydiving. We know that there's a pretty good correlation with mortality. A little segue. Again, I'm sure everyone here is pretty confident reading papers, and if you're not, then do have a read of Trish Greenhouse's How to Read a Paper. It's absolutely fantastic. And to add to that, the grade approach in systematic reviews, so a way of approaching how to review the quality of a systematic review and above is absolutely, I found it fascinating. It's really, really important. It's what we do generally when we read something. We look at the quality of something, but it really locks it down. And whether we allow other people to do that for us or just have an awareness that a lot of the data out there is not good quality. There's a lot of bias. So the approach basically says you're taking your certainty of evidence, you're looking at the factors that determine that certainty. So things like its design, its quality, consistency and directness. So for example, if there's a big magnitude of an effect, you can be pretty confident that there is at least an effect, something like that. And that gives us 4 levels of confidence as to how good the quality of evidence is. So back to the evidence. Doing an equivalent thing that I did for the Google, but just for social prescribing on PubMed, shows 222 results. You can see it's going up dramatically since about 2017. Moving on to systematic reviews and above, there's 11. There are a couple more out there, but these are the main ones. And what I'm trying to do today is give you a synopsis of this, give you a flavor, so you're not having to do all this yourself. Now, the topics covered make sense. That these guys. So in summary, it's how social prescribing works and how to do it well, whether it's impacting on things and also health service usage, and then its impact on specific health and wellbeing outcomes. So in a summary, how to do it well, how it affects health and wellbeing outcomes, and then is it cost effective? Those are big areas. Now, these are the potential outcomes that you can use to decide whether social prescribing is working. I'd like to focus just on health and wellbeing outcomes and cost, the big topics. But a little message about healthcare usage. It's a big parameter that we use for commissioning. But I think we should be very, very careful about how effective A&E attendances are, to use that as a proxy parameter for how good social prescribing is. I have been involved with data where they have used, oh, look, we've got reduced A&E attendances pre and post as proof, in inverted commas, that something works. But actually, if you continue to follow up the data, it was just a change in the service, the season, etc., etc. And I know there's ways of getting around confounding variables, but in my experience, there is a bias towards trying to prove things that sometimes overcomes that. And these are very blunt tools and a bit of a round peg in a square hole sometimes. There are sometimes examples when reducing general practice appointments is well correlated with people going to appropriate resources in the community. But my point is we should be very, very cautious that there aren't significant confounding variables, and we're not doing political science or headline science. So outcome measures that we use should have these characteristics. They should be valid. They should be useful, reliable, responsive, ethical, and simple and unburdensome. It's difficult to have all of those. There are so many different ones. There are probably 50 or 60. But I'd just like to go through a couple of them. ONS4, we're keeping how satisfied are we with our life nowadays, worthwhile, happiness and anxiety. Patient activation, so how empowered are people? We're trying to move them along. We know that the more empowered they are, the more they are able to focus on their health and have good health outcomes. I'll just flick through the questions there. I'll let you read that. You can see that these are good to measure their activation, but are they definitely good for social prescribing? Another major one is the Warwick Edinburgh. That's mental well-being. And again, it's all about mental well-being. So these are indirect correlates, aren't they? There's an absolute ton of others. But the question I have for you is, they all have value. But are they exactly what you would create to measure a social prescribing intervention? I'd be very interested to hear what you felt was important to go in. And perhaps what we need to do is create one of these validated scoring systems for social prescribing specifically. Perhaps that might be useful. There's also financial outcomes as well as the health and wellbeing ones. Now, I'm sure a lot of you have heard of social return on investment. Its principle is, for a pound spent, what do you get back? Now you can see for these 4 papers and analyses that were done, most of them are showing that you get more back than what you put in. One of them, Group A, crosses 1, which would be the crossing 0. But even then, the average is above 2. So probably social prescribing is cost effective, but it's difficult to say for sure. So what are these wider lessons from the literature? We can see each individual parameter, and it is showing gradually that we are improving in certain areas, but what are really the wider lessons? Well, read the conclusion for all of these. More high quality research and transparent reporting of findings is needed. There is a need for well-controlled studies and trials. However, it's important that these things are supported and informed by a high quality concomitant research program. There's more. Current evidence fails to provide sufficient detail to judge either success or value for money, and we urge researchers and practitioners to standardize definitions and metrics. These are important outcomes. So all of the things that we can't say, what can we say? Well, does social prescribing work? If anyone asks you that, they probably don't understand. What you need to ask is far more specific. What we do know is that we are starting to understand social prescribing and its impact on some health and wellbeing outcomes. Generally, trends are positive. We know that there are some good factors in effective social prescribing, and we know what they are generally. We know that it is positive towards depression, social isolation, health behaviours, mental health of those in financial insecurity, and indicators of wellbeing. Generally, it's positive. We also know that for those that have been well measured, it probably was cost effective. So it's probably worth investing in. So looking forward, well, we should look to answer very specific questions in well-designed studies that use valid and comparable outcomes to gradually build the picture. There are some people doing amazing work out there, and I just wanted to say thank you to them. There are many more, but thank you very much for all the work that you're doing if you are involved in social prescribing and, of course, in health and welfare. Thank you very much.